We'll begin. Okay, good afternoon. Um, this is our, I don't know what number webinar. Um, we're presenting, this is our JVP Health Advisory Council webinar, Bridging Healthcare Gaps for Palestinian Refugees with, I hope I don't pronounce your name wrong, Mejd Al-Azzeh and Henry Lewis, MD. Henry is an international medical director and family medicine physician working in Armenia and internationally, and he supervises all activities related to qualitative and quantitative data collection on program activities, and he works alongside a team of international advisors and contributes to a diverse array of development efforts, including community organizing and with groups such as one for three and H for Health for Palestine instead of abbreviating it, in Palestine, and he's worked all over the world. And Mejd has been the director of programs in Palestine. And she also works out of Armenia, and she's a director of programs for One for Three and also Health for Palestine, where she leads the organization's initiatives in the West Bank. Okay, if you folks want to begin, feel free.
Sounds good. Thank you.
Thank you for the introduction, Amy. Um, Henry, if you want to go ahead and start, and we'll...
Sounds good. Yeah. All right. And we'll have some time for questions at the end. So, as Amy mentioned, my name's Henry. I'm a family medicine doctor, and I've been working with the communities we'll talk about tonight in the West Bank and at our community center partners since 2017 now. And we're going to talk about Health for Palestine, which is a community health worker program. It's a special initiative of our partner One for Three, which is a nonprofit organization that's based out of Massachusetts. And there's a lot of interconnectedness between all the community centers and organizations that you'll hear us mention tonight. So if it sounds like there's many moving pieces, it's because there is, and we're all strongly linked and strongly partnered. So what is a community health worker program? Well, we're going to kind of take you through the life of that model as we have done it in the occupied West Bank, in Palestine, and show some pictures and some narratives and tell some stories about what it's been like to try and do health since 2018, and especially in the last year, in the West Bank. And we really focus on this model of social accompaniment. So health as medicine, but health as more than medicine, right? As walking with people and working with them. So, we'll cover 5 main themes or main approaches. We'll look at some problems. We'll talk about what it's like to work in Palestine. We'll talk about what we've seen in our work and ultimately what we do. And then lastly, we'll talk about how do we define success, right? How do we know if we are doing right by the community or if the community itself is healthy? This picture on the left here is a picture taken years ago, 5 or 6 years ago, maybe in Mukhayam, Ida, which is a UN or UNRWA-run Palestinian refugee camp in Bethlehem. It's about a fifth of a square kilometer in area, and it has about 6,500 people. And similar stories, if not more dense, in a lot of the other camps that we'll talk about today. So very densely populated spaces and refugee camps that were established in 1948 and have very much grown in community and vertically, even when the spaces around them have sort of tightened and the situation's gotten worse over the decades. So as a health program working in the West Bank, there were steps towards first partnering with communities and identifying, knowing how there might have been problems. And as I mentioned before, Mejd works for and runs One for Three in Palestine, which is a Boston-based NGO focusing on education, environment, and health. And they are really the impetus and catalyst for the health work that we do. Merkez Laji is one of our community center partners. It is a true community center that operates in the UN refugee camp in Bethlehem, and is a hub that I'll keep referring back to, is a community partner that has allowed us to do not just our health work, but a lot of the education work, has established a kindergarten environmental unit, things that Mejd will talk about as we go through the slides. And ultimately, the work we have done is through Health for Palestine, which is a community health worker program. We'll talk more about what that is. But we've had this international partnership both with myself at the University of Massachusetts Medical School, Harvard Medical School, and a number of other academic institutions, now including Boston Children's Hospital and Cornell Medical School as well. But again, we're not here to talk about academic institutions that are all over the world. We're here to figure out sort of how did we come to a point where we knew that a community health worker program would solve problems. And ultimately, we started not with fancy data or big research papers or anything like that. We did focus group discussions. So we went to community centers, we went to mosques, we went out into the camps years ago, now 2016, 2015, and asked focus group. We asked questions in focus group discussions. So we sat down with people, very broad sets of questions, not so much, what are the pertinent health issues that you see, but like, what is life like in the camp? What are barriers to wellness and barriers to community? Through that, the life of the program, we built community advisory boards and looked at how to speak as a community alongside each other. And we did population surveys as well. And, we gathered a lot of information and we followed ultimately the data that pointed us in the direction of where the program ended up, both treating, chronic disease and psychosocial issues and diabetes and hypertension. And I just wanted to look at a map that came from, I think this is from a WHO paper. My sources will be at the end, but this is a graph starting 2004, as you can see on the bottom left here, and progressing to 2011, shows the prevalence of diabetes. And you can see that there's a pretty impressive and unfortunate increase in the prevalence and rate of diabetes in the West Bank. So again, it was one of the issues that the community validated with the conversations that we were having in the community centers. And that kind of led us as a community health worker program to focus on chronic disease. So we certainly focused on diabetes. And I did want to bring attention because we're going to kind of bounce back and forth between how we built the program and what's going on in the West Bank currently, including a recap of a recent trip that a delegation that we did a few weeks ago to the West Bank as a team. This is a concerning projection of what the prevalence of type 2 diabetes, specifically in Gaza, could be in the coming couple years. You can see the reference at the bottom, but this is, if people understand sort of the prevalence of diabetes globally, it's certainly not close to 50%. And, if you fast forward a couple of years, this paper and other literature is suggesting that the prevalence of diabetes could be as high as 44% in men and 46% in women, which is crazy. A high community prevalence of diabetes would be something like 11%. So you're talking almost 1 in every 2 people. And from our working in UN refugee camps in the West Bank with Palestinian communities, we have really been shown that factors, it's not by accident, it's not genetic, it's not access to food or insulin, but profound stress, profound trauma, what's going on in Gaza and the West Bank currently, and then the longevity of the occupation as well, really exacerbating these health conditions. But, we can stop looking at charts and speak to the community, and that's what we've done. That's what we did again as a refresher 2 weeks ago when myself, other physicians, and many members of our team went to the West Bank, went to UN refugee camps all over the West Bank, including in Nablus, Tulkarm, and Bethlehem. And we sat down with communities and we asked questions, the same questions we asked, 6 or 7 years ago, as to what are the obstacles to health, to being healthy? What are the biggest problems that you face in the camps? What are issues that if you have our support or the support of your community, want to focus on? And things that came up were, we ultimately did a qualitative study to, ask those questions. What were the community perceptions of health burdens and needs? What was access like to UN facilities or health facilities in Palestine? What is it like now? What are the barriers to care and potential solutions that come up? I think what's interesting is 6 years ago, the solutions were, it would be really nice to have community members, young people that we train and can go to people's homes, sit with them for a half hour or an hour, drink coffee, listen to their issues, listen to their concerns, check blood pressure, check blood sugar, but ultimately provide, a voice to listen to sit there in this model of social accompaniment. You can find interesting studies as physicians that, show that just talking to someone about taking their diabetes medications is as effective as actually taking the medications themselves. So you can see drops in, our biomedical markers, your hemoglobin A1C. If I give you a medication that helps with that, like metformin, but I also sit with you and talk to you about that, it can decrease your biomedical markers at the same time. And that's a model that we pushed. And that accompaniment, that idea of sitting with someone and listening to them is specifically, and it's very pertinent and important in Palestine. There's quite a bit to process. There was 6 years ago, there was before that, and in the past year, it's been an incredibly difficult situation as well. And we'll focus in now about where we started and then where we've expanded to as a program as well. And Mejd, if you want to sort of take over here and talk about some of the spaces that we do work in.
Sounds good. Thank you so much, Henry. So yes, so we work as 1-for-3. We work across the West Bank in various refugee camps, 5 now in total. Like Henry mentioned, we started in Bethlehem in Aida refugee camp, and we have another camp called Aida. Aida camp, as well as Azzeh camps. So Aida camp, like all refugee camps across the West Bank, were established around 1950, which was after UNRWA, the UN Work Relief Agency, was created after the Nakba, the catastrophe, where 750,000 Palestinians were uprooted and displaced from their homes. Over 500 villages were destroyed, and people started migrating to the nearest, safest city to their home villages. And so Aida camp consists of from people from about 27 different villages surrounding the Hebron and Bethlehem area, as well as Jerusalem. In other refugee camps in the north, they may be from the northern cities that are nearby those refugee camps. And so in the previous slide, I was going to go over kind of how Palestine has been divided after 1950, especially after the Oslo Accords in 1993. Historic Palestine is the entire map that we see here. And then it was divided into Gaza Strip, which is, we know what's going on there at the moment. We have the West Bank, and then we have Greater Palestine, which is now called Israel. Within the West Bank, it's even further divided and fragmented into 3 main areas. Area A being under Palestinian Authority control. You have Area B where it's supposed to be joint control, but these areas really, you can't expand as a Palestinian. You can't build on it. It's really whoever has homes and farmlands there, they're able to stay there, but you cannot expand into those areas. And then Area C is under full military Israeli control. And so for Palestinians living there, these are the areas that are most under threat today more than ever before. That's where you find all the farmlands, all the water and electrical resources, which are all now controlled by Israel, although they are supposed to be under Palestinian control. Sorry, next slide, Henry. So in Haida camp, oh, sorry, can we go back? Thanks. In Haida camp, like Henry said, it's less than a kilometer squared area, and the majority of refugee camps are of that size, if not smaller. We have about 8,000 residents living in Haida camp, and then another 2,000 in Azzeh camp, which is right across the street from Haida. These are probably the smaller of the two the camps that you would find within the West Bank. In Balata, for example, in Nablus, it's the largest in the West Bank with over 35,000 residents living in it in the same small area that we're seeing here. Tulkarem has about 22,000, which is the second largest. And we'll talk a little bit more about those camps and their living conditions. To go back to Haida camp, we're completely surrounded by the apartheid wall, which you can see in the photo here. This is Haida camp. Laji Center is circled in yellow, which is one of our partners in the West Bank. And then completely surrounded by the wall with 6 military watchtowers that are manned 24/7 by snipers, as well as a military base near Rachel's tomb. Now, this is important because Rachel's tomb is an important religious site, not just for the Jewish religion, but for all monotheistic religions, and has always been there. However, a military base was built right there to protect the tomb and the religious site, and also visitors who are coming nearby. This is not a problem until the military starts attacking the residents of Haida camp, which is very close proximity, as you can see in the photo. The military would easily come down the main road that is in front of the Laji Center where we work, and conduct military raids, arrests, and as well as shooting tear gas, live bullets, anything of that sort. So you can imagine living under these conditions constantly. There is a lot of trauma and stress within the community, from the youngest to the oldest that you would find. And that's how we started our work in refugee camps. In the photos that you see here, this is an example of what the apartheid wall looks like with the military watchtower, as well as in the lower photo, I put that there specifically to show you how right across from the Laji Center is considered Area C, whereas on the other side where Laji Center is, that's considered Area A. And so Area C is where the water and electrical supply for the entire community in Haida camp and Greater Bethlehem is being controlled. Just to give you an idea. Next slide, please. Thanks. So again, in 1950, UNRWA was created and people were migrating to the nearest safest areas to their villages. They lived in tents until about 1956, until UNRWA realized that people cannot keep living under these kind of conditions, especially in the cold winter months and hot summer days. They decided to build 3x3 meter bedroom homes. For a family of 6 or less, you get 1 bedroom home. For a family of 7 or more, you'll get two of those two-bedroom homes. And so the photo on the right is one of those last remaining original UNRWA homes. As people started working and saving up money, they were able to build on top of those original homes because families have expanded without any open space or areas left to build on. And so we see in the photos here, the tall buildings within the refugee camps is because people are forced to build up because they cannot expand out anymore. In the top right photo is, you can kind of see the UNRWA Medical Center that is located in Aida refugee camp. Almost all refugee camps have one medical center. If not in every camp, in at least, like for example, in Bethlehem, this medical center serves the 3 refugee camps in Bethlehem area. They have very few services there, and Henry, I'm sure, will touch more about UNRWA services or the lack thereof. Yeah, their hours of operation are very limited, and again, very few services there. In the bottom right photo, we'll see a small area in Aida camp. You'll notice water tanks everywhere, whether on the ground or on the rooftops, because again, water is a scarce resource here that is controlled on a monthly basis. The water will come around for 2 or 3 days, and people in the entire area have to fill up their water tanks. They don't have free running water. They have to fill up their water tanks, and that should last them for cooking, cleaning, dishes, laundry, anything you can think of for the entire month until the water comes back around the next month. And so we began our work with the Laji Center due to all of these constraints on refugee communities. Laji Center is a community center that was established in 2000 in Aida camp after a group of young men realized that there are no open spaces for children and families to enjoy. There are no safe activities or things that children can be involved in. And so they created the Laji Center out of a couple of garages in the middle of Aida camp until they were able to get enough support and donations to purchase the building and the land behind the Laji Center. They have a wide array of activities and programs, including media and arts, library, the health and environmental unit, music, DEPKE, a women's unit, gym, circus school, a kindergarten, and a soccer league. These activities are not just there for people's enjoyment, but they also, the staff and volunteers that work within these programs in Laji Center, really work with the community on various levels. And it all goes back to working with children and families who are suffering constant trauma and stress due to the occupation. Again, this is an updated photo of the Laji Center after we've built our hydroponic units on the rooftops. Again, this is the Laji Center right here and how we are very close in distance to the military base. And just a few photos to give you an idea of all the different activities and the different age groups that the Laji Center and our other partners in different refugee camps are working with. Again, various activities for education, of course, fun, but also to really work on the psychosocial support for the community to bring everyone together.
Thank you, Mejd. I'm going to talk briefly about the trip that One for Three and Health for Palestine did a few weeks ago to the West Bank. That for me was sort of a refresher. I had been back a few times in the past year, but I had not been back with our bigger team and our bigger delegation. We were very deliberate this time about going to see all of our partners across the West Bank. So this is a picture from Merkez Jaffa in Balata refugee camp in Nablus, which is a city north of Bethlehem. As Mejd mentioned, Ida camp is a very densely populated space, talking 6,500 people in a fifth of a square kilometer. I think Balata camp is two-fifths of a square kilometer about, and it's 35,000 people. As a family medicine physician, I see very big gaps in access to primary care services, overwhelmed clinics, overworked providers, a lack of nursing, a lack of access to medications, a lack of access to basic labs, lab testing, diagnostic testing, screening. In these community centers like Merkez Laji or Laji Center and Yafa Center, that is, cultural equivalent that sits in Balata refugee camp, have really, in some ways, unfairly taken on the burden of what the Palestinian healthcare system or any healthcare system, primary care or specialized, should be doing. So you have, community health workers who are just people, the only requisite to be a community health worker, according to the WHO, is that you must be from the community that you're serving. You don't need to have any formal training, any formal skills or requisites. It is people that represent themselves that then can be trained on how to be sort of paraprofessionals, but ultimately it's some mix of social worker, health worker, and community organizer. That is essentially what a community health worker is. So these are the community health workers from Merkez Jaffa, and some of them are nurses who got their 2-year bachelors of nursing, and with unemployment being what it is since the war, since October 7th, a lot of workers have pursued these community-oriented jobs. We have social workers on these teams. Some of them are educators or just simply community organizers as well. So it's really refreshing to be back in Balata with our team. Refreshing in some ways, but really hard in other ways to hear about the acuity and the difficulty of cases. I mean, I had heard diagnostic measures that I have never heard before. Hemoglobin A1C is over 16 or 17 points, which is very, very high for those of you that are familiar with those types of markers. And, it's hard to speak to where UNRWA is headed and what the future holds on a large scale and politically, but I can say that UNRWA was wildly underfunded and very understaffed a year ago, 2 years ago, 3 years ago. So to face, budget cuts and this possible impending or looming redirection of funding completely, if UNRWA is to fall at some point, that would be catastrophic for the healthcare system in Palestine, for the Palestinian refugee camps that are in these UN camps. And that would put more burden on community programs like this, which is, it's great to see community taking health into its own hands, but the prospect of not having any public system is very daunting. So, this is from a health point of view, from a public health point of view, a very dangerous moment in terms of what will happen next and what services will be cut, pediatric, adult, obstetric, and otherwise. But there's moments of hope like this at the same time. Communities coming together and providing care and doing their best to work with international groups, UNRWA, the ministry, hospitals, wherever it might be. We were also able to go to Tulkarm, and it was a very difficult time getting there. We saw, a result of a lot of the invasions and conflict that had been happening just days prior to when we had arrived. And these are some images of homes that were destroyed. You can see sort of on the left there that the roads had been bulldozed. There are these big construction machines that intentionally drag essentially an anchor that cuts through concrete behind them, bulldozers, and really tears up roads and water infrastructure and other things. And some of the camp residents were telling us that it's 3 weeks to get water back running in main lines. So a lot of communities will just rely on the water tanks that Mejd had mentioned before, but those tanks don't last for 3 weeks for a family. So really, really difficult access to water. And, sorry to show these images, but again, just some spaces in UN camps in the West Bank that have been flattened and destroyed. So, you know, these community health services serve to support these teams, and our new partners in the Tulkarm area have been doing a lot of care prior to when we arrived. So going in, we focus a lot on diabetes and hypertension, but the team in Tulkarm had been doing a lot more sort of trauma response and, in very dangerous settings when there had been incursions or attacks in the camps. Some of the community health workers that we now work with had been injured or shot, and very tough moments to see. So we are glad to be, trying to support them and partnering with them moving forward. So, I mentioned that we kind of bouncing back and forth between this most recent trip and what, has been built at Merkez Laji and what we've seen in the past. And these themes persist, whether it was when we started in 2016 or we're right up to today. Sometimes the volume is termed way up or way down, usually way up. But these social determinants of health, right? Things that are beyond our genetic makeup or, what we eat necessarily, clogging arteries or whatever we perceive health to be. These were 4 themes that came up and continue to come up in Palestine. The occupation of land and displacement of people, mass incarceration, then and now. We have a community health worker that, has been taken and incarcerated, who we do not have contact with, and we're hoping that we get him back to us very soon. Poverty and unemployment, and ultimately a fractured healthcare system. Quotes that have come up through the years. When the army comes, we're trapped in the camp. I got sick and was not able to go to the hospital because of the army. They didn't let me pass. This is a slide that represents just, orienting ourselves to Bethlehem, sort of redundant in terms of what Mejd had already shown, but there up to a couple of years ago, 2020, there was not a health center in Ida camp. There was not an UNRWA health center in Ida camp. There is now, as Mejd had shown, and there are in various camps, and you can see all these blue dots are UNRWA camps throughout the West Bank. And just a quick visual representation, repeating sort of what Mejd had shown before. I think when I talk to people about health in the West Bank, there's often a misconception that there's not access to hospitals anywhere, or things are remote or just sort of barren. But this is a visual representation of 2 of the camps we work in Bethlehem. And then all of these H's are 1, 2, 3, 4, 5, 6, 7, 8, 9 different hospitals that are pretty much within walking distance in Bethlehem. But it sounds nice, but when you factor in all of these things, right? Like military incursions on almost a daily basis, systemic mistrust of systems, displacement, mass incarceration, that cumulative effect makes walking to these hospitals, seeking care, trusting physicians in certain settings really, really difficult. So it's sort of this health desert, even though it doesn't necessarily look that way. And, you can probably see that in cities you live in or work in, even in the US. I think back to Boston and, the discrepancy of access, where you have to head for your healthcare, whether it's Boston Medical Center versus MGH versus, somewhere in Worcester. There's so many obstacles to getting to these places, and that's really, really pertinent and really, really obvious in parts of Palestine as well. When you go back to photos like this and your roads are torn up and the army had been around you for 48 hours, you don't really want to leave your house, right? You want to hide and protect yourself. Run quickly. These are some of the things that we treat in these settings. So your chronic diseases, diabetes, hypertension, COPD and asthma, depression and mental health disorders, but a lot of this stemming from and exacerbated by psychosocial trauma and cumulative trauma. We focus right now on diabetes and hypertension. But diabetes and hypertension overlap with so many other disorders, cardiovascular disease, certain activities like smoking. And we've since also expanded, and I'll talk a little bit about that at the end, to pediatric care and well-child exams and what it means to, go see your pediatrician and develop normally as a kid in Palestine, and then trying to provide support whenever there might be issues with development or developmental delay. Again, sort of repeating myself here, these are themes that came up from when we originally asked questions that persist to today. What are the barriers to health? What are the barriers to care? Occupation, the occupation, poverty, health system and provider distrust, trauma and psychological impact. And then I found one really interesting: lack of agency. What do I mean by lack, or what do the community mean by lack of agency? At the time, I think one illustrative way to talk about that is you go in with the misconception that you want to teach someone what is a healthy diet for heart health or diabetes health. And people generally know, right? Like, don't drink tons of soda, don't eat tons of fried food, don't overdose on carbohydrates. But there's so many barriers on a systems level that get in the way of making that a reality, that just to tell someone that, it's a little bit, patronizing in some ways. So that lack of agency, whether it's food's too expensive, and inability to have time in your busy schedule because your permit just got pulled and now you have to work 2 jobs through the day, for example, or, your culture's land being taken and you're not able to grow the foods that, are your right to grow. All of these things create a lack of agency. And if I just tell someone to stop drinking Coke or soda or something like that, doesn't land as well as a physician. And that was something that the community told us. It's like, we get it, but there's so many obstacles, and that persists to today in a lot of the conversations we have. So ultimately, we started this community health worker program. We go on home visits. It's a very high touch model. Community health workers will go in pairs, sit with families on a weekly basis, check blood pressure, check blood sugar. They collect data on all of this. And ultimately, we'll go back in time, they work to send people within the healthcare system, right? Like, okay, you have chest pain, right? It's been persisting for a week. I know you don't want to leave. I know you don't want to go. What can we do to get you to Beit Jala Hospital, for example, so that you can get an EKG or an echocardiogram? Do you want me to go with you? Would that be more comfortable? So really this model of accompaniment, walking with patients through tough moments. There's a physician named Dan Palazuelos at Harvard that has a great quote, that community health workers are the antidote to the ignorance of the expert, right? So physicians or labs or clinics can often be there and, give orders, and orders that aren't necessarily followed up on. But our CHWs at Laji Center, through Health for Palestine and One for Three, just make things happen, right? And making things happen in medicine is everything. And this is a great visual representation of what our CHWs do. So they do some biomedical stuff. They treat diabetes, they treat hypertension, they check your blood sugar, they check your blood pressure. They do a ton of social and psychosocial support in the form of trauma and resilience care. And then within Palestine specifically, they do political education and community mobilization. What are your rights within the UN refugee camps? How do we stand in solidarity as a community? Laji Center is a perfect hub for medical days and educational exercises, and just, days off, right? Like sort of a community breakfast. The value of just getting together with your community and sitting as a team is quite high. And ultimately, we work to try and fix systems, although that is something I've been sort of losing sleep on the last 2 weeks since we got back from Palestine, is if UNRWA falls and is no longer providing healthcare, what system are you trying to fix? It's a very concerning thing moving forward into 2025, something that would affect not just our program, but like health systems on a whole. And we're sort of ending or nearing the end of the presentation. We'll take some questions. I just have a few last slides if we have time. I think we've got a few more minutes to go through a couple slides. I do just want to emphasize everything we do focuses on trauma-informed care. Trauma-informed care is a way of practicing health. You recognize the prevalence of an individual's trauma. You identify the impact that that cumulative effect has throughout someone's life. You respond with understanding, and you integrate that into all aspects of the health. And I consider it sort of a form of integrating behavioral health. Functionally, a lot of residencies or medical schools in the US are taking on this concept of trauma-informed care, or if they're not, they should be, where you're considering, what has this patient gone through? What types of interactions are gonna, get me further as a physician and gain trust? And not small things like Ida Camp being one of the most tear-gassed spaces in the world, talking to someone about asthma and just telling them to take their inhaler, for example, does not consider the profound amounts of exposure and breathing issues and childhood events that might have been related to tear gas exposure in the first place. So we developed a curriculum, something that is publicly accessible called Kurkum, that was built by a collective team centered out of Palestine. That was a collective focused on decolonial healing, essentially a workbook that looked at psychosocial support and trauma-informed care. Functionally, it is physically a book that you can go through and do exercises and talk about, what is the intersection between health, culture, trauma, resistance, healing. So it's something that, you don't get the return on trying to fix someone's blood pressure with just medications. You make those effects with considering these cumulative effects of trauma and psychosocial support. So ultimately in our program, we moved, this is sort of the last section I'll have, and then we'll open it up to questions. But, always ask ourselves, how do we define success? And I think there's a few ways to do it. You do it with numbers. So we track everything, right? And this is one of our interfaces where we can see for every patient we have now over 15,000 home visits since 2018, where I can look, each row here is some patient data. So I can see, this person had a blood pressure of 115/74, which is really good, right? And I can see that live time if I'm in Boston or if I'm in Armenia or wherever I am. But this person probably needs to take their medications or needs a visit from the CHWs. That's 150/98. Not quite where we want it to be. So you can harness this data over years and publish it and show to medical and scientific communities that the CHW model works. And that's what we did. We did a retrospective match cohort study for the first 2 years of the program. Basically, what we did was we compared our patient population who had CHWs to the UN controls, the patients in the communities that didn't have CHWs, and we showed that there was an increase in the rate of control of diabetes, looking at A1Cs, and a decrease in blood pressure. So quickly to go through these scary charts, this circle here is our patient population that had CHWs. So A, top and bottom, and then B, top and bottom are the UN controls. All right, so time one, 6 years ago, let's say, people were pretty much on both, those that were our patient population and the UN patients, 50-50, right? 50% controlled, 50% not controlled. Fast forward a couple of years, we could see that 77% of our patients, those that had the CHWs, became controlled, and only 23% were not controlled. Fast forward 5 years for the UN patients that didn't have our CHWs, pretty much stayed the same. In fact, it got a little bit worse. What does this mean? It means CHW programs are really strong health interventions in many settings. And we were really happy to harness that data. But to come back to this question, how do you define success? I always find those numbers secondary to what the community tells us. And we now we started with 6, now we have, sorry, this should say community health workers. We have 27 total community health workers with 3 pediatric community health workers. I think there was a moment at the end of our trip 2 weeks ago where we looked at each other and like, this is not really a small project anymore, right? Like 27 full-time health workers is a substantial amount of support that we're giving. We will now work in 5 UN refugee camps and operate within 3 community centers with over 15,000 home visits. And, as the situation in Palestine worsens in Gaza and the West Bank, um, success was defined, I think, largely by the communities asking for more. They saw these 6 community health workers and they said, 27 sounds better. And I think that was really validating, even more validating than publications or things like that, because the community perceived it to be effective. And now we have quite a bit more work to do, but we're very excited to keep building towards health as a bigger community.
Well, thank you. I'm Alice Rothchild. I'm going to be monitoring the questions that I'm happy for people to put in the chat.
Oh,
Is that okay, Amy?
yeah, I didn't see any.
Oh, yeah, there's a bunch here. So let me
Oh, okay.
go through these. And I should say this is this is being recorded, and we will be sharing this recording, and it will be on the Health Advisory Council website, jvphealth.org. So the question is, you mentioned the critical need for UNRWA. Can you also give an overview of, quote, official healthcare structure for refugees on the West Bank? What does the Palestinian Health Authority do? What, if any, resources come from Israel? What is the legal responsibility of occupier for health of those occupied? And what support do the community health workers accompanying project get from, quote, established healthcare systems?
Yeah, I'll do my best to answer some of those questions because that's a huge discussion. I think if I look at a snapshot of the healthcare system, UNRWA in the UN space in Mejd, correct me if I'm wrong, is responsible for health within the UN refugee camps. There are different insurance plans that also come from the Ministry of Health, depending on, if you work for the Palestinian Authority or if you have, military standing, you can even live within the camp and get that insurance model and then go outside the camp to a Ministry of Health hospital, for example, and get those services. I think it is complicated in terms of, health insurance is always complicated, but it depends on who you are and where you're living. Mejd, I don't know if you want to jump in a little bit and speak
Yeah.
more to that.
Yeah, so like Henry said, UNRWA is the responsible entity for all refugees, not just living in refugee camps, but for example, if you're living in the city, you've moved out of the refugee camps, you're still considered a refugee. And so it is their obligation to provide services, whether it's healthcare, education, and many other things, which they've decreased over the years. Now, the Palestinian Authority is also responsible. However, it's based on whether you work for the government or you can apply for the government health care, and there are certain things that they will cover depending on your financial situation. The occupier, they don't offer services to the Palestinians at all. In very rare cases where you'll need a specialist that isn't found here in the West Bank, for example, you might be able to get a permit that needs to be approved by Israel to go to one of their hospitals in Jerusalem or Tel Aviv or elsewhere. However, it's almost always denied, and so you're not able to get through. And also you have to go through checkpoints and many other restrictions on movement to even get there in the first place. So it's almost impossible to even get that kind of care from the occupier.
Did you want to say more, or should I move on to the next question?
Yeah. Oh, please go ahead.
So there is a question about speech language therapists, and are they involved in community services and audiologists as well? What is the scene there?
Yeah. I mean, I don't know too much, but that is something we're going to start to get more involved in as we work towards pediatrics and specifically developmental delay. From my experience, a lot of speech language pathologists or therapists, it's largely been private access and often expensive, and outside of the camps with special pathways for referrals that are needed. I do think we're going to learn a lot about that as we expand to the pediatric space. So, happy to share if, contacts and learn more, and share more as we learn more about that.
Okay. And one person wants to know how to get that curriculum, the what is it?
Yeah, we can share that.
Do you
I
want
don't
to
know if
put
it'd be
that in the
possible to
chat?
send. Yeah, I can put it in the chat. Yeah.
That'd be great. So I have a question. I know that smoking is a huge issue in the occupied territories for obvious reasons. What is your approach with that, or how do you deal with that as community health workers and knowing that this is a huge societal issue that contributes to all the diseases that we're seeing?
Right.
Yeah, it's a good question.
Yeah.
It's a hard question
That's a
from
hard
a
one for
primary
sure.
care perspective to look at.
It's hard
Yeah.
everywhere.
Um,
I mean, from a cultural aspect, we're very careful about telling people what to do or not to do, especially when it comes to, smoking is a type of stress reliever for a lot of people. However, we do have a lot of, workshops or activities for our health patients to educate them on the effects of, for example, smoking or eating healthy or not healthy, going to the gym, exercising, healthy diets, things like that. And so it goes back to them at the end of the day, how they'd like to proceed, as far as we've had a lot of people being more active in our gym that's located in the Laji Center, for example, being active in our environmental unit as far as growing and harvesting their own organic foods. So there's certain things that we can kind of help change in our communities. However, there's other things that just are out of our control sometimes.
Yeah, especially exercise in a small camp without any green space,
Yeah,
and
very.
particularly for women, could be very difficult.
yeah.
Definitely. Yeah.
And I'll say to the smoking point too, I mean, it's an incredibly hard thing from a behavioral health point of view, to do like behavioral change around smoking. And I think that, especially in really stressful spaces, it's hard to talk to people about like, hey, that one thing that brings you a lot of relief at the end of the day, stop doing that. So I do think there's a certain amount of difficulty when it's like on an individual level. I think impactful smoking interventions come from a public health policy space. And, if there's no public health as things fall apart, then that will become even bigger and issue further down the road. So.
And one person asks, given the trauma-informed care, what do the counseling mental health services look like through your program?
Yeah, for our program, it's come in different forms in different seasons. So a lot of what we do is, trauma-informed care, not even formal screening, but just social accompaniment. When an issue does come up, we have referral pathways through an on-call, on-staff physician, and formal referrals to either psychology or psychiatry services outside of the camp within Bethlehem. But that's, that faces all the obstacles we talked about before in terms of access and cost and getting to a place. So our program itself has not provided direct psychological and certainly not psychiatric care, but it is something now as stress and trauma increase at an alarming rate, we are approaching of like, would it be helpful to have a psychologist on staff? So.
And you didn't speak at all about how this whole thing is funded. I think that would be important for people to know.
Yeah.
Sure. Mejd, do you want to speak to that?
Sure, yeah. So our funding all comes from friends and supporters who, just like yourselves, who hear about our work, are inspired by it, and would like to help in our expansion efforts. So like we mentioned previously, we started off with, 6 community health workers in one camp, and now we're up to 5 refugee camps throughout the West Bank with 27 different community health workers. And it really comes from supporters, private supporters, friends, donors, who just really want to help us in our efforts.
Yep.
So
And
people
we're,
wanted to support the organization. Do they go to 143 or how do they do that?
yeah, would it be okay to, we're running a end of year campaign now, and if it's okay, we can put a link to our
Sure,
page
you can put it in the chat. Yeah.
Thanks.
It's actually right now our fundraising campaign, completely forgot to mention, but it's going towards specifically the health program, and especially for Tulkarem, Nur Shams, and Balata camps, because those are the areas that need the help the most right now, given their situations at the moment. Yeah.
And I will mention we do have a new foundational partner, a group called DIFA, or Diabetes Education for All, which is a group of diabetologists and endocrinologists associated with Harvard and the Joslin Center, who are supporting us and have, supported us in terms of our ability to hire more community health workers. So they are a strong new partner.
And can clinicians volunteer with the organization to go out on home visits and back up the healthcare workers, or how does that work?
Yeah, we brought physicians from all different academic spaces, from UMass and Harvard and Cornell. And, I think we're now positioned to host more people, thinking about a delegation as well in the summer. So, yes.
And how do people find out about that?
We're happy to share our information, and once we have calls, towards like whether it's a summer delegation that will be upcoming, we would put that on the 143 page. There's also a newsletter through 143 that you can sign up for, but we can also share our information.
Okay.
Yeah, exactly.
Any other questions in the chat? Anybody else do you have anything, Amy?
Yeah, I just had a question about pediatrics. Do you train the community health workers to deal with young pediatrics, in terms of feeding or, things like that?
Yeah. So, I mean, we're in the pilot phase of our pediatric expansion, and we're really looking at first-time parents and walking
Right.
them through what it's like to have a kid and what it's like to feed and, not sleep and look at growth charts and things like that. And yeah, we're really excited to start there. So, yes.
Great.
Oh, okay.
One
I
more
was
question
curious.
came through, which is how can Jewish Voice for Peace help? Or I assume Jewish Voice for Peace Health Advisory Council also help this project. So is it mostly financial support or volunteers or what?
Right. Can we volunteer?
Yeah, I mean, I think a combination of those two things are great. Volunteer opportunities have helped us and continue to help us, and that's how a lot of our continued our now like permanent staff and partners kind of started volunteering at the beginning. So yeah, Mejd, we can think of a way to best share our information to sort of take people in and hear from them. Yeah,
Exactly.
and then a rising tide floats all ships in terms of any support as well to keep 90% of our funding goes directly towards salaries for the CHWs as well. So the more CHWs we have for longer, the more we can volunteer and support them.
And is there anyone, when we go to the website, is there anyone specifically that we refer to if we wanted to volunteer? Like if we go to 143?
Mejd.
Yeah. So you'll find our executive director there, Nidal Al-Azraq.
Okay.
You can find all of our contact information. So please feel free to reach out to any one of us, and we'll get back to you with the information and how to get involved, and yeah, any other questions or information that you need. Definitely.
Okay. There's also an interesting question here. Someone wants to know, has there been any repression of your organization in the United States due to your work with Palestinians? You know, has there been any blowback
Mm.
to your organization or to any of you personally?
So of course, especially given the political climate that we're entering right now,
Right,
there is a lot of fear on Palestinian organizations and U.S. organizations working in Palestine. First thing, financially, we're afraid that more restrictions will be in place on us. Getting money into Palestine to help support our work is one of our biggest fears. But then we also have the community pressures of, people don't want organizations or other people to get involved in Palestine because they don't want people to know what's actually happening on the ground. Like we were talking about Tulkarem earlier, unless you go there in person, yes, you hear about Tulkarem being having incursions all the time, house demolitions and things like that, but you don't really fathom the extent of the attacks and incursions until you go there in person.
right.
And so, of course, yes, there have been repercussions, and although we hope that things will get better, we really just don't know at this point.
Okay, do you want to wrap it up, Amy?
Okay. Thank you all for attending. Thank you very much, Henry and Mejd, for giving us so much information and letting us know what it's really like in the West Bank and bridging, healthcare in the refugee camps. And hopefully there won't be a total destruction of UNRWA. We'll cross our fingers. And letting us know how we can contribute and also volunteer if we wish to, and how we can help. So thank you so much.
And
Thank
people
you.
should know we have more webinars coming up in January.
Yes.
We have Maya Wind,
Maya Wind in January.
and she's written an incredible book about the complicity of Israeli institutions with the occupation. And then we have ones coming up on the impact of infectious disease on Gaza. And we're working on a whole host of monthly webinars going forward. So we hope everyone shows up
Yes.
for those too. So thank you all.
Yes, thank you all very, very much. And
And
Thank you, everyone.
this is JVP Health Advisory Council. Thank you.
jvphealth.org. Okay, take
Yes.
care.
Take care.